welcome to Cardiology Update, viewers and listeners. My name is Chadi Alraies. I'm an interventional cardiologist at Detroit Medical Center in Detroit, Michigan, United States. Today, I'm going to talk about a very interesting, recently published article related of Redo-TAVR. Today will be, as very interesting, is a structural paper again, and as we know, with the evolving field of structural heart and a growing population and the indication for low and intermediate risk, this population has been growing in age and 10, 15 years beyond the first implantation of TAVR. So this paper looked specifically about the outcome of this cohort of patients who require a redo TAVR after receiving a valve replacement in the past. The title of the paper is Safety and Efficacy of Repeat Transcatheter Aortic Valve Replacement, or Redo-TAVR, in National Registry. And again, in the Europe and also coming up in the US, the TAVR terminology is changing to TAVI, indicating intervention. Again, in the light of a growing number of patients kind of outgrowing the age of the valve, as well as the need for second valve due to degenerative the malfunctioning of the valve due to stenosis or regurgitation. So again, as I mentioned earlier, there is an indication for these patients to have another valve. This research paper published by Dr. Makar is encompass all consecutive patient registry in the Society of Thoracic Surgery, American College of Cardiology Transcatheter Valve Registry from November 2011. Again, this is 4 years after implementation of the TAVR, all the way to December 30th, 2022. These are patients who underwent TAVR with a balloon expandable either for failed transcatheter heart valves, meaning surgical valve or Redo-TAVR, or for native valves or native TAVR, among a total of more than 350,000 patients, 1,000 in the Redo-TAVR group and 349,000 plus in the native TAVR group. The analysis focused on the 1,300 plus patients who were well matched in terms of propensity redo TAVR or native TAVR. So again, this is a propensity match analysis, and we know there is some pitfall to this propensity, but this is going to be the best way to evaluate this cohort of patients using this methodology and statistics. The study revealed that redo TAVR had relatively low rate of procedural complication, which were comparable to those observed in native TAVR procedure. When we spoke about complication, the most obvious one is going to be the vascular complication that this patient has, because we know that they have other comorbidity that put them at risk for peripheral arterial disease. Therefore, these patients will have risk for peripheral arterial disease and complication. So that their rate of death at 30 days was 4.7 versus 4, and 1 year was 17 versus 19 with a p-value of 0.57, not significant, as well as a stroke at 30 days, 2 compared to 1.9, and 1 year 3.2 to 3.5 between the Redo-TAVR as well as the native TAVR population. Redo-TAVR resulted in a reduction of aortic valve gradient at 1 year, although these gradients were slightly higher in the Redo-TAVR group compared to the native group, and this is expected. That's 15 millimeter mercury compared to 12. Why is that? Because when we do redo, again, you are measuring by the annulus, and when you are implanting valve and valve, you are losing some space, and that's going to create lower gradient, a higher gradient. But again, this gradient was in the mild range. The rates of moderate or severe aortic regurgitation at 1 year were similar in both redo and native TAVR valves, and this has been seen in most registries and trials recently because the type of valve we have and the durability of these valves are really good. The type of index of transcatheter valve, balloon expandable or non-balloon expandable, did not significantly impact. So whether you are using a balloon expandable valve or a self-expanding valve, the outcome is not different, which is a good signal and also important, especially if there is some selection of these patients for certain valve compared to the other. So this analysis was completely not biased to any certain valve because this is all comers all on the registry. Finally, in summary, the study indicated that Redo-TAVR using balloon expandable valve effectively addresses this function following initial TAVR procedure with low rates of procedural complication, MI, death, vascular, stroke, and it yields death and stroke rate similar to those observed in patients with comparable clinical outcome and predicted risk undergoing TAVR for native valves. The author concludes that Redo-TAVR with balloon-expandable valve may potentially represent a reasonable treatment option for selected patients with failed TAVR. Why this important, and why this study? I really, I'm thanks for the team for picking this article. Why this is important in clinical practice? Because we know that now with low and intermediate risk into the indication for TAVRs, have been implanting a younger population with TAVRs that can be as low as the age of 60, young as 65, 62. And these patients are going to outlive that valve and they're going to require another valve intervention. So these patients already made the selection for TAVR. So when you are talking about redo the valve and you bring up the surgical intervention, I think it's going to be unfavorable discussion with, especially for the patient perspective, but also if the patient was picked for a TAVR, maybe a TAVR, Redo-TAVR is a good option for these patients, as shown in this paper, this findings, and it's really assuring that risk of complications. So the Redo-TAVR does not associate with any complication as long as we select the right patient, as well as we are doing it in a safe fashion, and also with the durable valves that we have currently in the market. I would like to congratulate the authors for this wonderful paper that really shed a big light on a good number of population that we're going to be facing soon. The bigger question is for these valves, and I think it was not addressed in the paper, is the access of the coronaries. Now we have two layers of valves that are implanted in these patients. So maybe the technique and how we are implanting these valves maybe has to be looked into before implanting the second valve, because you don't want to jeopardize the access for the left main or the RCA in this population. Again, thank you for joining me today. Please visit cardiology-update.com, as well as the social media platform. As you know, Cardiology Update comes to you on LinkedIn, on Instagram, Facebook, and Twitter or X. And so watch for any update. And I'm Chadi Alraies from Detroit Medical Center from Detroit, Michigan, United States. Thank you for watching.